Today, in particular, we're going to be talking about the BRiCS course, and I'm happy that my friend Carrie and Debbie and Patty all joined me for this. It's a session that they are all the esteemed faculty for, and I'll properly introduce them in a minute. But I just want to talk about what this session has now become. Um, we used to just call it Third Thursdays because we were doing it once a month. And some folks reached out and said, boy, it would be awesome if I could send my team to this session every week. Do you have enough content for it? And because I was a administrator slash um, administrative hack for so long, I feel like there's a lot to talk about. We were in a place where I felt like whenever we wanted to implement something new, we kind of had to make it up for ourselves. And I called a lot of people like you on the line, and Candy Simerson and Cindy Haskell and others, and learned a lot from it. So we wanted to have just a place where we can report out on the kind of implementation we want in a way that's easily compilable on the website, and then also a place where we can talk about new technologies and how we can implement them, new ways to manage practice. So that became what is now practice habits. We think that habit makes things stick. I love, the concept behind atomic habits. I feel like it's been core to my personal life and professional life. And the same things when, you know, put through the scope of how we manage practice. Um, can be really powerful for you and your team. And so that's where we're going as far as the naming of this kind of education. And then we also want to practice whatever those habits are. So doing it on a routine basis is really helpful. Um, as I mentioned, we've got Patty and Debbie and Carrie here we have now three of the four corners of the US. I don't know if you ladies ever really noticed that. But that's pretty impressive that
Mhm.
everybody is so far flung. We just need somebody in San Diego and we may have this thing nailed. But really impressive group of leaders. Each of them have spent hard time in the ASOA leadership roles. Carrie, of course, being the president now. And they were the faculty, are the faculty, along with a few doctors who have executed on this concept of the business of refractive cataract surgery. And that was a session that was held this last weekend. We had about 70 practices or so in attendance, probably 30 or 40 folks from industry as well. And it was really collaborative between doctors and their business kind of associate, the person who helps them implement their number two, and then industry. And so I just wanted to ask a question, first of all, and I'll kind of just call on you guys, but you can all jump in. But Carrie, why BRiCS in the first place? What was missing that we needed another meeting?
Well, I think that the biggest aha moment is if you think back to the adoption of presbyopia correcting IOLs and toric IOLs, that was we were able to charge for those back in 2005 and
Hmm.
2008. But yet fast forward 20 years and the adoption rate was less than 20%. In most industry wide, I think it was about 18%. And so, where's the disconnect where we have such an amazing opportunity to provide patients the quality of vision that they're striving for, they're looking for, but yet we don't know how to execute on it. And so, talking to other practices, they couldn't figure out how to do it. And you'd think after 20 years that practices would be all dialed in, but they're not. And with declining reimbursements, this is truly the opportunity, the time to grab the bull by the horns and say, what can we do to change this?
Yeah, and Debbie, what's been some of what are the reasons that there's been friction or that there's been low adoption up till now, in your opinion?
Yeah, I think a lot of it is communication with your team and making sure that it's not just that there isn't that disconnect between the doctors and the rest of the team. I also think that, the doctors really don't like to talk about something they have to charge for. They're not comfortable with it. And they kind of, um, after at our when I went to the first BRiCS meeting, my doctor, he wanted nothing to do with that conversation of pricing. And after he went to that first meeting, he just had this comfort level where he felt like, what we're providing patients is what they want, and we are giving them, vision that they haven't had for many, many years and they're going to have for the rest of their life. So we knew that we had to get them to that comfort level where they felt like it's okay to ask. It's okay to ask patients to pay for something that's going to restore their vision.
And Patty, you have an interesting perspective because you run/ran a big practice, but now you also have a front row seat into how that plays a part in a larger organization that's trying to implement changes. Maybe share a little bit of your perspective as to the difficulty that this opportunity, the refractive cataract surgery category presents to a group that large.
Yeah, so I think infrastructure becomes the biggest area. That's for small or large. And I think ASCRS and ASOA, partnering together on the business side of this helps no matter the size, whether you're private equity or you're a single one location surgeon, learning to develop the infrastructure that encompasses all so many areas, whether it's patient experience, customer service, bringing in the surgical skills, the technology, how to speak to these patients, how to train our staff to handle an experience that is a little different than just a standard Medicare issue item of any kind. But on the large scale, I think it becomes even more complex. The small doc office, you can sit everybody down each morning and you can have a discussion and you can continue to build on that relationship, if you will, of communication. Larger scale on so many different levels, whether it's surgical skill or I want to provide it, but this doctor doesn't want to provide it. And by the way, we want to provide this lens and this doctor doesn't want that type of lens. There becomes a lot more discussions with processes that vary throughout the organization. So it does add not one more layer, about 100 different layers of understanding and development.
Yeah, well, I'd like to, so it does, and yet there's still some core things that can help you scale, right? Because the minute you decide you're going to do this, there's some technology conversations we have to talk to. There's team orientation and training. There's how that all works through the system. How are we going to price it? How are we going to bill for it? Because isn't there an insurance part of this? And then, oh, by the way, there could be an opportunity for us to talk to the optometric community about it as well. Seems like a lot. What are some of the ways that you eat the elephant, Carrie?
So, on that, you also are looking at, with iHealth America, which I'm a part of now, we're across 3 states. And across 3 states, it's almost impossible to attach the same pricing in multiple communities and multiple economic levels, right? So the complexities of being able to figure that out is important too. But for me, we do a lot of training through videos, through recorded videos where everybody can, study the subject, hear the subject, test on the subject, and then repeat, rinse and repeat, right? Because it's constant. You never stop training ever.
I agree, Patty, that no matter the size of your organization, you have to focus on your team first because they're the ones that are going to usher through what you're trying to do, right? So if you're looking at the whole elephant and you're not prioritizing the team as the first step to success, you're not going to change that percentage of conversion. You're not going to have complete buy-in. I think whatever, when we were shut down during COVID and we had 95% of my employees furloughed, we were doing weekly Zoom meetings like this, not to be like, oh, hey, how are you doing? That was part of it, but we use as an opportunity to educate and keep educating and growing the team. So I think somehow figuring out how to prioritize that time in your busy practices, you need to figure it out. There has to be a consistent approach to team training.
And I think too, targeting, like, for me, I look at almost my system as almost like the nation, look at what the nation and the capture rate is within the nation. I have a capture rate across 3 states where some of my largest surgeons, the surgeons with the largest volume, have the lowest capture rate. So there's so much opportunity to educate and really impress and give a better patient experience to all of those patients.
Yeah,
Well,
and
and
I think
sometimes the better capture rate is it can be a little bit of a misnomer. Sometimes people are in such a groove because they're so operationally efficient that it's hard
Yeah.
for them to stop and educate a patient about a new offering. I mean, it takes a little bit longer. It takes you a little bit out of the flow. I've found personally that practices that are high volume might have a hard time unless they're willing to really, take a Saturday, to just really work on the choreography.
Mhm.
Because you have to move furniture, so to speak, in how you see patients. Debbie, I cut you off. Sorry about that.
Yeah, no, that's okay. I was just going to say, and it goes to what you just said. I think, what we've had a lot of success with is scripting. You have to have scripting available for your staff for each touch point, and that goes beyond the just the BRiCS and the business of cataract refractive surgery. It goes for everything. How are your people answering their phone? Do they all have the same message? How are your counselors naming the packages that you offer? Does if your package is called basic or advanced technology, is that carrying through in all of your anything on paper, anything on your website, videos that you're showing patients? You want to be consistent so that everybody, not only the patients, but so that the staff understand what those terms mean, because it is confusing when you say in one sentence, so premium, and then the other you're saying advanced technology or traditional. You just have to get everybody on the same page. So I think scripting and role playing are essential with your team to get everybody on board.
And I
Yeah,
think the
I
why,
like that.
understanding the why. Why are we doing this as a practice? I think if the staff also needs to know the why, then they're going to have a better understanding of where the goals we're trying to reach.
One of the things I heard each one of you talk about is we call it the customer experience cycle, but it's really the patient experience cycle. I don't mind using those words interchangeably because it reminds our frontline team that, hey, these are our customers.
Mhm.
Sometimes we think if they're carrying insurance, that they're going to kind of maybe just take whatever we give them. But when we call them customers, man, it feels a little bit more Main Street, and that can never hurt. But
Yeah.
we talked about the customer experience cycle quite a bit, and I think that was a handy way to break down the work. And so, in the absence of having it, maybe just describe what that is, Debbie, and how you used it to communicate the different steps of the process.
Yeah, and I think it starts with that phone call, even before that. What does your website look like? Does it have the information that your patients are going to be able to, that they need and that they can refer to and refer their family members to? And then that phone call, how are the phones being answered when they're scheduling the appointments? How are the appointments being scheduled? You don't want to find out that, oh, your scheduler is booking the cataract evaluations 3 months out. You want to make sure that everybody's consistent and they know these are the slots. And if we don't have the slots, we're going to make the slots. And then throughout the workup, you want to make sure your workflow is really consistent. So your workup team, they have the same script that they're working with a patient on. And then when you get them onto testing, that you have your testing really, really central, and that everything can be as close to each other as possible. So it's easy for the patient. These patients are elderly. They have to move, we don't want them to have to move around too much. And then at what point does your doctor see the patient? Is it before the counselor? Is it after? Do you have an OD working with the MD? All of those touch points are really, really important for that patient experience to be what we want it to be. And the great thing is we have so many industry partners out there that have tools to help us through all the steps of the patient experience. And, for us, we had to take a step back and say, we don't have time to educate all of our patients before they come in, but we do everything for our cataract patients in one visit. So how can we streamline that so they're educated when they come in before our counselor sees them? And so we outsource that. We work with Navigate, and they call all of our cataract patients beforehand, and they're just like a staff member for us. They have the script. They go off of our script, educate the patient, then they're already pre-educated when they come into our door. So all those touch points are so important.
That's a really good breakdown of the customer experience cycle. What I like to say, and then I'll ask you, Patti, maybe if you have any more color on it. But what I like to say is that, you take the stage of the phone call, and it goes all the way to the workup, and the entry, the workup, the testing, all the way down to the consult itself, and then all the way back up through counseling and scheduling and leaving, and what happens between that and the next cycle, which is being reminded, your reminder call to come in for surgery. But so all of those elements that make up the cycle of that patient experience, um, we like to break it into stages. And then we define what is a non-negotiable thing that has to happen in each of these stages. And there's usually 5 or 6. There might be more, but no matter if one person shows up, or or you're overstaffed, here's the minimum requirements that we're going to do on a phone call to talk about refractive cataract surgery, or during the testing to talk about refractive cataract surgery. And it's just such a nice way to break down the work, and have team members know, okay, so I'm booking, I'm scheduling right now, but I know that they've probably already heard this 3 or 4 times, because I know what the non-negotiables are in the stages before mine. Patti, anything to add there?
Yeah, I think being very intentional with all of your staff understanding all of the roles, right? This is
Mm,
like a big orchestrated dance, if you will. And we need each dance partner to know the steps so that no one trips over the other person, and everyone can pick up. If somebody does falter a step, let's pick it back up and run with it. And that's so important. And the only way you get that is to develop a real culture of your team understanding all of those steps. And I will say, and making sure that everybody understands those core principles, but limiting those that don't to other areas. So being intentional about which staff are the ones that are touching these patients, right? How do we make sure that they get into the right silo, they fall under the right
mhm.
hands, they hear the same messages, that everybody works together. Our goal is always for our patients to be really educated about which lenses we offer prior to the physician even walking into the room with them the first time. So there is no deer in the headlights look when the doctor starts making recommendations, but you only get that by being very, very intentional with these patient types. Cataract patients are such a commodity for all of us, that it is important that we're able to capture that at the upper echelon level.
You know, um, you're exactly right, and I like that you said they're such a commodity. They're we should be growing, um,
Mhm.
much at a much greater rate in just even basic cataract surgery than we are.
Mhm.
Um, and so I think we only grew 2 or 2.5% last year, when the aging population suggests that maybe it should have been more like 7. And that's not including any advanced options. That should be hopefully growing even more as well. So there is a big opportunity out there, and we have a lot of reasons, like you mentioned, reimbursement,
Mhm.
cuts coming, cost of the team coming. And I think we can try to do it all in-house ourselves. And I would have said back when I was running a practice that we're going to be in-house the single best, biller, phone answer, or marketer. It's kind of what kind of our mentality. And yet at this conference that we had, there's all kinds of partners in the marketplace. So I'm going to talk to a couple of them here right now, but Debbie, Carrie, and Patti, I'm going to come back to you in one moment. And when I do, um, and stay on, keep your camera on, otherwise we won't see you. But I'm going to be asking
Mhm.
you for your most powerful and salient point or takeaway that you're implementing first from the BRiCS course, because you guys have stellar practices, but you're still implementing new things that you learned last week. I want to introduce Kate and Chris, because there were a couple of practices who mentioned these businesses' names, and Chris, you were at the BRiCS event. First of all, I'd like you to give us an overview of what you think the value is of a conference like that, and then um, explain what your role is in helping practices on this topic.
I think the value is, there's so many different opportunities for surgeons to get together and discuss the clinical aspect of how we can improve upon not only care but also transitioning to making these lens options a little more available. But there was this gap, right, in ways where everyone can get together. And I think you put it best. It's not just the faculty on stage, but really encouraging and engaging with the audience participation, which to me was one of the most valuable parts of hearing everyone that was attending have an opportunity to speak about uh, their focuses, their needs, their goals of the business side. Obviously, it's pretty spot on with the name of BRiCS, but really, I think the value of that meeting, and this was the second year that we were attending, and we're really excited to attend again next year, is that it really takes into account all the things that you could do to better the patient experience that lead to really great outcomes, but of course lead to really great outcomes for your business as well. Um, and you asked
No,
kind
just like Debbie just did a little intro of kind of using you in one of the stages of the process. Maybe give us a sense of what your offering is and where it happens in the life cycle of the patient.
Yeah, we were formed with the idea that there's not enough patients choosing premium lens technology, and years ago maybe that was surgeons had a misconception that the technology couldn't keep up. But we have so many great there's so many great options now in terms of technology that we can meet the needs of the patient and meet the expectations of the patient. So our job at Navigate is to not only set appropriate expectations, but educate patients on their upcoming cataract journey, on what options might be made available for the practice. And we do that by becoming the virtual education team for the practices that we support. And I think Debbie put it really well. The practices that we support do a really good job already, right? They have really great technicians, they have a really great team, and these are things that they could do today. But there's so many other things that your staff has to do. So we hire experienced technicians who all day, every day, that is their sole focus, is educating those patients so that it becomes less of a responsibility of the practice, and they can just see those patients walk in the door prepared, ready to make a decision, and feeling a little bit less anxious or uncomfortable with all the things they're about to learn over a 90 to 120-minute cataract eval.
Yeah, and you call out after an appointment is scheduled. So Debbie's team will have scheduled the cataract appointment and said, "Hey, somebody, working for Doctor, is going to be calling you to maybe share some information with you. Take that call." And then your team calls out and does that education.
That's right, and Debbie's team does a great job of it as well. They set the expectation that someone from
Hmm.
their team is going to call, right? We frankly we don't care if a patient knows who Navigate is, so we treat ourselves as an extension of the practice. So yeah, my team is going to call today on behalf of Dr. Atwal. We want to talk to you about the options that he's going to potentially make available to you, and so we're just another touch point from the practice and the patient's eyes. And I think the benefit of reaching out to them before that visit is we can treat that call as a focus on education without being pushy or salesy, some of the feedback that we heard during that BRiCS meeting, and make it so it's a lot easier for that surgeon to make that recommendation in the office as well without feeling like they have to be the one to break the ice on out-of-pocket expense or cost for the patient as well.
And last, I'll have you keep this answer short, but um, uh, bottom line, does adoption increase with the practices you work with?
Yeah, on average, we see 30% higher rates of premium adoption for patients educated by a navigator or educated ahead of time compared to a patient going through a traditional education process. So short answer is yes.
So if I'm a doctor I'm just doing the math at home here because I'm a South Dakotan and I got to sound it out. If I'm doing 30%, that practice average, everybody's different, may jump to 40. And that I think the reason I say that is because, those kinds of numbers are really impactful to the practice, but you found some things that you didn't expect, which is technician happiness, because they walk in and a lot of the human side of things, what they do for a living, how they use their vision is already in the record. And then that you already discussed certain technologies already in the record, because your technicians are the navigator technicians are entering the data right into the form for the patient, and it saves time as a natural outcome to that. So that's a nice 1-2 punch. Thanks for turning your camera on for me. I texted him in the middle of saying, "Hey, turn your camera on. I'm about to call on you." So And Cade he left his on because he wants to prove to the world that he's got a sport coat, and and
Not
that
to the
he's wearing
world,
it on
just
a
you, my friend, just
yeah
you.
on a day where I'm not wearing one. So we're gonna have to do a who wore it best. Um,
Yeah.
Cade, there was a section that was talking about the most impactful marketing for this category, and your business came up, and because we were talking about some of the rudiments of follow through. Right, it's not as easy as just having a good message. We really need to do what we say, and if we're going to prompt people to call, then we need to make sure we pick up the phone. Give us a little overview of maybe your offering, and then also just from a general overview. I know you were really on the fence this year because you're a new company. Between this and going to one of the bigger national meetings, and was decided with you being the main person who does the traveling to not be in attendance at BRiCS. I'm not going to publicly call you out on that, but
I'm
I
not for
just
sure
wanted
what you
to,
just did, but okay.
yeah. But give me a sense of why you think it's
Yeah,
important,
yeah.
and then tell us about your offering.
Yeah, well, thanks for including me. That was not my expectation. We all know that the patient experience is really multifaceted, from the marketing and the messaging, like you just referred to, and then all the other, components of the patient experience that a clinic is dealing with and managing. I appreciate what Debbie said. It's like there's no way a clinic can do everything, and that's kind of what we believe about like the new patient lead follow-up. Typically, practice has a person or a team of people who are wearing 5 different hats, trying to answer existing patient calls, existing patient communication, new patient calls, and new patient leads that are coming in from your marketing efforts. So what Boost does exclusively, we do no marketing, and we do nothing like what Chris does in terms of booked consult patient education, is we just obsess over that new patient lead follow-up. So speed to lead and joyful persistence are the name of the game for us, where we're an extension, just like Navigate, of your team. They do not know Boost exists, they don't need to know, but we just obsess over speed to lead, joyful persistence, so that we can increase your consultations. And we can do a little education. We can answer their questions based on, I think someone else said, scripts and things like that. Same thing for us. We've got your knowledge base. We're answering questions on behalf of your practice like you like it to be answered. And our obsession is increasing your consults, because we know that when they're sitting in front of your team and your doctors, they're going to be cared for. And so you're going to grow your surgery volume by having more consults. So that's really what we obsess over, and so grateful. 72 practices, and we're up to about 50 ophthalmology practices. So we're not a new company, but we have only been in ophthalmology for about 15 months and have been really grateful for the number of practices who have trusted us.
Thank you. Yeah, and yeah. Sorry for the new company
Oh, it's
part, and thanks.
okay. I
Thanks.
know that you like to give me a hard time, but it's fine.
Yeah, no, and thanks for correcting me publicly.
And I will be at BRiCS next year because we're newbie to ophthalmology. Just can't keep up with all the meetings, and it was a
Yeah,
real mess. I was having serious FOMO when Sean Priest was like posting all his pictures, and Patty, you
yeah.
were in one of those, and I'm like, oh man, what am I thinking?
Well, I want to say thanks for that, Cade, and you can certainly stay on. Please do. But I really have to hand it to Patty and Debbie and Carrie, who with Vance, my mentor and friend, who created this course with ASOA to really be a blueprint for how a practice should go about doing more. Now, here's the dirty secret: the operational excellence, these rudiments, the customer experience cycle that we study at the BRiCS course, it's really how to implement anything.
It
Like
is.
if you go to a course about the business of interventional glaucoma, which you should, which is also put on by Askers and ASOA, you're going to see the same customer experience cycle. We're just doing different things at each stage for that practice type. So when you learn to implement, and you can do it at scale, you learn to implement anything. And that is really, really important for these practices. So I'd just like to ask you three in as our kind of our last question here today, and I'll start with you, Debbie, and we'll work backwards and end with you, Carrie. But just give me a sense of what the most potent piece of implementation you took from BRiCS this year.
Well, I think a couple things. I think speaking of CADE and Boost, that I wrote that down in my notes to go to research that when I get back. So somebody was talking about it at the meeting. But also, I think, for us, the little pearls that I brought back is somebody mentioned, I'm not sure who it was, a 30-day phone call for the patient after 30 days after their surgery. And we do a really, really, really great job getting them to surgery, getting them for their 1-day post-op, their 1 or 2 week follow-up. And, after their second eye's done, okay, we'll see you in 3 months, or we'll send you back to your optometrist. And that's kind of where it sits unless they need a YAG. So I really love that suggestion that somebody made, do a 30-day call, 30 days after surgery, just to check and see how they're doing. So we're definitely going to implement that. And Carrie had a really good suggestion. She has her front desk person, greeter, standing. And I think that's really so great because, your patients come in and you've got this person sitting at the desk, probably looking at their phone, not making eye contact. If they're standing, that's really welcoming for the patient. So those are just a couple things I took back, but it's just an incredible meeting.
Yeah, excellent. Those are great, great points. Maybe just to add on to yours is, Advanced Thompson Vision, they also do a 100-day visit. And they try to do that one in person. It's a no charge visit. It's no fee, but it's really to get some of our own records. If some of the optometric community, isn't following through on sharing those, which they're getting better at, but it's not, they don't wake up in the morning trying to make sure our files are complete.
Right.
But that is to make sure that if a patient needs a fine tune or needs a little tear film rehabilitation or whatever, that we're not leaving them on the 2-yard line with this big investment they just made. So good. Patti, how about you?
So I want to make 2 points. One, you talked about the patient journey being pretty much the same for almost everything we do. We did do a breakout session on AII, which was the adoption, implementation, and integration of new technology, which also, Matt, applies the same thing. You can take those same principles and apply it to almost anything new for your practice. And we had a wonderful breakout session on that. So, and that was a program that was introduced in LA by ASCRS and ASOA at the meeting. That was one of our pre-meetings. So that it does applies to everything. But on one of my big takeaways is just what you were just talking about, and that is the time frame. We tend to build our packages and build the patient experience around the first 90 to 120 days based on the care and the follow-up needed for that particular surgical procedure. But the takeaway that Vance Thompson uses is, a year. Like, plan it out for the year. And I think that's so important for relationships. And that just really made a light bulb go off that why not get these patients back? We're a practice that is not co-management. So every single one of those patients matter to us, helping them remember who took great care of them, who did their cataract surgery, how are they doing, where are they now a year later, so that then they can, introduce this to other patients and refer them to us. I think it's a big, big takeaway.
Yeah, and just to add more color to that, what Patti's referencing is when a patient has an advanced IOL along with cataract surgery, before they leave their consult day, they'll have their 4 or 5 post-op visits scheduled, for after surgery with their provider of choice. Oftentimes, because of where we live, that's their primary eye care provider, right? And so they're leaving with all those appointments, and then at the end, there's one more with us. Well, that requires them getting on the phone with the practice that refers to us and doing this warm transfer of scheduling in real time. It takes a minute, but it's completely tucked in then between the 2 practices, and the patient feels completely covered for the long term. And it's part of why we feel justified in offering what we do at such a high price.
Exactly.
Carrie, bring us home.
I think the unsexy part of this is know what you are actually charging for, what is in your package, so that you stay compliant and it makes sense. So where we really dialed in this year, and we had Mary Pat Johnson from Corcoran Consulting with us to keep us on the right path, is, are you just throwing a dart at the board and picking a number like, oh, that looks like a good number, that's what I'm worth? Where you should be laying out everything that you're doing, every single test that you're doing, diagnostic, the additional visits and chair time, everything that you're putting together. Your team is part of that. If you're using Navigate, if you're using Boost, whatever you're adding to your patient experience, you're building out in how you're pricing your services, right? And I know we talked a little bit about, amortizing enhancements and things like that. So that's separate from this, but I think really understanding and valuing who you are based on what you're providing and owning what you charge. And I think the other piece is, remember that the patient, Matt, I love how you said this early, the patient is a consumer of medicine. They're used to having choices and buying. They're not afraid of that, but they need to believe and trust you to actually make that commitment for that service.
One of my friends who helped start this category in 2005, Andy Corley, says, nobody likes to be sold, but everybody likes to buy. When they see something of value that interests them, a lot in that statement, right? So if they can see the value that you're bringing, then you can really be confident in charging a premium. But I love what you say about owning it. A lot of providers don't feel comfortable with the pricing thing. I heard a lot of tables talk about how one of the things they're going to do is go home and raise their price based on the exercise. So listen, I mean, it's a broad overview. We just talked for 40 minutes about a full 2-day conference, a Friday afternoon and evening, a full Saturday and a half day on Sunday. And we couldn't do it justice, but I do want to congratulate you three on all of your work on it. The role playing, the scripting, the promoting you did of it. And because I think that I talked to a practice pretty regularly who went last year and couldn't make it this year, but they've gone from 12% to 30% adoption, which is only one piece of the report card, right?
Mm-hmm.
But their team is also really happy and they're really proud and they've got some swagger, and that feels good. P.S. They're also making a lot of patients happy. So that's the bottom line for all of it. I want to just open it up now for anybody who might have any questions. We've got a lot of folks on the call. So ladies, thanks for being the popular crowd. You can unmute if you want to ask a question or hop off, turn on your camera. Happy to take any of your questions about the BRiCS course or really anything related to admin leadership.
I think this is a really good presentation. I really respect the heck out of everybody at this panel. Well, except Matt, but that's beside the point. I wanted to go to the BRiCS conference, couldn't make it this year. I'm aiming to do it next year. But I did do the glaucoma thing earlier this year, and that was fantastic. And you start to see patterns of implementation and what you need to do from tip to tail. I like the concept of owning it, because when we start talking about prices on lenses, we get a lot of hemming and hawing, and it's like, you know what, guys, stop that. That's if it's like my kids, if they detect an ounce of weakness, they're just going to run away or attack, one of the two. So I think that's the conversation we need to have with them. We do some education, and at some point in time, I'd like to engage in Chris and Kate and see what they have to do. But no, I appreciate the conversation, Matt. Yeah,
you bring up a really good point, and I haven't done it for a while, but a lot of times I like to come to the meetings like BRiCS, having done a look at Best Buy and Costco to see what the most expensive flat screen TV is, because people they don't negotiate that price or hem and haw for the best visual outcome with something that hangs on their wall, yet they're happy to look through their janky, hyperopic, not cleaned lenses in front of their eyes, hyperopic correction, to do so. And I think that we can learn something from that.
We really can.
That we have something of real value that people might feel okay questioning, but if we look to our sisters and brothers in the other healthcare subspecialties, the dentistry world, the orthodontics world, the the breast aug world, plastics, they charge a premium, and we don't ever hear price wars from those folks. Something to really learn there. Thanks for the comment, Bill, and none taken.
Actually, my my docs, they'll get squirrely about saying this is the price. And if they get squirrely about it, then it's the lack of confidence can permeate, and that's never fun. So yeah. So
just a little
no.
tip for that, because we talked about that a lot. A little tip for that can get the doctors off the hook is in what I'm recommending to you. We've got a few different options there. It ranges from 4,800 to 5,200 per eye. Marsha's going to go through that in the next room and talk about how people afford it and pay for it. But I just wanted you to know that's the range we're in.
Okay,
And
that makes
that
that's
gives them a
reasonable.
little bit less. It's $5,000 and then a cold, steady look. Don't blink. It's not. They don't have to do it like that.
Yeah, I think
No,
too, if
no.
you're pre-educating them on the pricing, in that pre-education call, and you're talking about the packages, you can talk about the range as well. And that way they're not going to prompt the doctor with that question because they already have it on their mind. You're already talking about financing options and how easy it is to pay for it over time. And then when they come to see the doctor, they're really, really focused on what package is going to be best for them. And it's, I think, an easier conversation for the doctor.
Yeah, I was going to add with Care Credit, you can pre-qualify patients, and you can even say for as low as $195 a month, will that fit into your budget? You can help make this happen. So sometimes, a lot of consumers don't pay lump sums ever. Everything is what fits into my monthly budget. So thinking in terms of that too is very helpful for the patients.
True.
Great point. Great point, team. Any other comments or questions from the gallery?
And I think just going on that price, another thing we talked about at the BRiCS meeting was if you are not having any patient pushback, you're not valuing yourself high enough.
That's true.
Listen, I'll because I tend to do webinars for a few companies. One of the things I do is talk to a lot of doctors about their pricing, in particular for the light adjustable lens. And one of the things I find almost unilaterally is that it's 5 to 10% above the other packages, and I haven't found very many, maybe hold one, where it's below 5,000 per eye. Okay. Now, so that's just kind of a little data point there, and I can't really advise you en masse on pricing. We don't want to get into a kind of a price fixing scenario here, but what I will say is that I happened to, at the tables I was at, I'd be secretly going through everybody's website around me, so I'd just kind of size up, how sophisticated there are or whatever. And one practice has it published right on their website that the light adjustable lens is $7,600 per eye plus copay, co-insurance, and deductible. And I was so happy for them because of how confident they were in their pricing. And I pulled that person aside and just talked to them about it. And they said, yeah, we've creeped up our price over time. And we just think it's worth it because of all the time we put into it. The technology is worth it. People don't say no to this lens when we recommend it because it's patients really get the benefit. Like I get to decide along the way. And so they've priced it in such a way. And I think as an industry, if we can get better at that, we might not be, if we ask anybody in the country right now, their biggest fear over the next 12 months, reimbursement.
Yeah.
How can that be? That's the worst.
Yeah.
It's almost something that we can do, we can lobby for it, but we should be taking care of ourselves in ways we can control.
And I think too, looking at those packages on a regular basis, you add technology and you don't, you want to make sure that that's added into your package. So, for
Mhm.
example, we implemented eye trace, and that's something that is not, not a covered by insurance. So we went and added that to our package, and it increased our package price. So you really want to look at those yearly and see, where you're at, and are you, too low? Are you too high, or where you are, and reconfigure? Or maybe you're doing, more refractions than you did when you first got your package pricing 5 years ago. So, or you've increased that refraction price. So it's important to just keep an eye on that every year.
Thank you. We'll see you all at Academy next week. But before, on the Thursday before, at the same time, we're going to be doing a session on implementing IG, which is going to be a major push this next year and going into askers. A few practices have done it really well. And not only is it a great thing for patients, but it reimburses in a way that's just as good or better than cataract surgery. And it's just sitting there in our practices. So we can help a lot of people and our team by doing well at that. We'll see you next week. Carrie, Debbie, Patty, thanks for joining. Sorry about my internet.
No worries.
Thanks.
Thank
Thanks,
Bye,
you.
Matt.
everybody.
Good
It's good
week,
seeing you.
everybody.
Bye-bye.
And Matt, thanks for all your work on BRiCS as well.
Yes.
Thank you.